mental health services that are available here. And then we have the surgical disciplines. Before I go to that, we have the pediatrics and child health. Now, in pediatrics and child health, what is unique with Jinja is that our pediatric department is located in another campus of the hospital. We have two campuses. So we have Nalufenya campus, where our pediatric department is. And in that campus, we see about 150 to 200 children every day. And we have quite a number of admissions. And we think in the future that could become a specialized children's hospital of its own, because there's 80 acres of land and the clientele is really very big that we serve in there. That is briefly what Jinja Regional Hospital is.
Good evening, viewers. I welcome you to this DOCtalk show. I'm by the names Dr. Kibuuka Afizi, consultant physician and head clinical and deputy hospital director, Jinja Regional Hospital. And with me, I'm with
Dr. Agatha Namutosi Wakama. I'm an associate consultant pediatrician at Jinja Regional Referral Hospital.
As a hospital, the commonest cause of our hospital admissions, both outpatient and inpatient, is malaria. Malaria is an infectious disease which is caused by a protozoa spread by mosquitoes, following mosquito bites on human beings. And malaria being the commonest cause of this, and also is the commonest cause of morbidity and mortality among the patients admitted in the facility. I will invite my colleague, Dr. Agatha, to tell us more about the burden and the risk factors of this. Why do we have this high number of malaria cases in the region, and what's really the burden and the prevalence of this disease within the region? Doctor, welcome.
Thank you very much, Dr. Afizi. I'll talk mostly about the children, the pediatric population. Malaria is such a high burden in this age group, especially for children under 5 years. Annually, we get about 16 million cases of people infected with malaria in the country, and 2 million of those being children under 5 years, which is a very high burden in that age group. And malaria itself contributes about 40 to 50% of both the outpatient and the inpatient admissions of all the children that we are having, especially in our hospital here. Even the large number of deaths, we lose about 2 patients every week due to malaria. So why is it such a high burden, especially for children under 5 years? Malaria is the mode of spread. It's spread by a vector called female Anopheles mosquito. And the younger you are, the lower your immunity is. So young children under the age of 5 are at a high risk of getting malaria. Also, the same as pregnant women. But even among the children, we have those who are at a higher risk for severe disease, including children with sickle cell anemia.
Also in the adults, because of most adults who have immunosuppression, either they have diabetes, they have HIV, another issue causing immunosuppression, we see that also they do present with malaria, as we have seen in children, but also we have seen that within the adult population, we are seeing an increasing trend of malaria cases also among the adolescents. More so the school-going, boarding kids, we are seeing also there's a lot of malaria there. Meaning that the epidemiology is changing. We are seeing also other than young children and pregnant women, also we are seeing in the adolescents. And this is the reason being that most of them stay in these boarding schools, there are no mosquito nets, they are crowded, they are dark, mosquitoes can hide there. And that also, I think, also could add on to the burden.
And they stay up during prep time in the classrooms,
For example, in our setting here in Musoga, we think why we are having these high numbers of malaria cases, the nature of economic activities which take place here. Here, most people are agriculturalists. They grow sugarcane, they grow rice in these rice swamps. This increases the breeding area for mosquitoes. because you find people growing sugarcane up the entrance of the house. And these sugarcane leaves act as, they keep some little just as stagnant water, which provides a breeding area for some of these mosquitoes. Then Musoga as a region is gifted with a number of swamps and water bodies. And all these act as also risk factors for spreading of malaria. When we look at the nature of houses, because maybe either because of the poverty, some of the households they have, these, they favor the breeding of these mosquitoes, and thus alone will increase the number of malaria cases, in that mosquitoes, they are breeding, there are so many, and they are infected and end up spreading what? This disease. So that's, I would think on top of the immune issues, but also the environment and the economic activities in place within the area, and the issue of the water bodies, these play a big role in the spread of this disease called malaria. For now, to summarize this all, we have seen that malaria is the commonest cause of admissions at Jinja Regional Referral Hospital, both in adults and in children. And we say that it causes a high mortality and morbidity, whereby it reaches an extent that we lose about 2 children per week due to malaria and associated complications. And we're seeing that our economic activities like agriculture, the presence of the many water bodies, these play a very big role in the the spread of the disease, and that puts risk both to children under 5 and also to pregnant mothers. But we are seeing a growing trend of malaria cases also among adolescents, the school going, whereby also you should have really high index of what? Suspicion. More so those are between like 5 to 12 years also, they are at high risk. I think with that, I request that we go for a short break. When we come back, we shall continue from there with the clinical presentation and also management of malaria.
This message is from the Ministry of Health with support from partners.
Since 2015, Quiz Mali Production has been at the forefront of media innovation. Our passion for storytelling and creativity has driven us to deliver over 100 successful projects, making a lasting impact on the industry. With 4 highly acclaimed TV shows, we've become a household name, bringing quality content to your screens. At Quiz Mali Production, we specialize in content creation, digital media marketing, media buying and documentaries. We plan corporate events, provide top-notch photography and videography services, and offer seamless translations and live streams for your every need. Join the hundreds of satisfied clients who trust us to bring their visions to life. Quiz Mali Production, your partner in media excellence. Visit us at Quiz Mali and let's create something amazing together.
Looking for instant excitement? The Uganda National Lottery Spin for Cash game is now available online. Wherever you are, you can join the excitement for just 500, 1,000 and 2,000 Uganda shillings. Don't miss out. Register now on www.nationallottery.go.ug for a chance to win your share of 2 billion instantly. What are you waiting for? Play Spin for Cash now, anytime, anywhere. Ituba is the proud operator of the Uganda National Lottery.
Uganda National Lottery. Dream, play, win.
Participants must be 18 years or older. Play responsibly. The Uganda National Lottery is operated by Ituba Uganda and regulated by the National Lotteries and Gaming Regulatory Board.
You are watching the DOCtalk Show.
This message is from the Ministry of Health with support from partners.
Welcome back from the break. During the break, we are joined by our colleague, Dr. Tentwa Emmanuel, whom I request to introduce himself. Doctor.
Good evening, our dear viewers. You are most welcome to DOCtalk Show. I'm Dr. Tentwa Emmanuel. I'm a consultant pediatrician and a cardiologist working at the Jinja Regional Referral Hospital. You are most welcome and nice having you.
Yeah, viewers, when we went for the break, we had covered the burden of malaria, where we saw that malaria causes a number of deaths and also contributes to a number of hospital admissions. And also during that time, we talked about why do we have high malaria cases in Jinja, Usoga region in particular. And there we highlighted one, the kind of activities which take place there, the economic activity, which is agriculture, which involves sugarcane growing, rice growing, and also the presence of many water bodies and swamps within the region. And this probably flows up the spread of the disease. This session, we are going to talk about the clinical presentation. How do patients really present? How do you know that this patient really has malaria when they come to the hospital? So that when you look at those symptoms or how the patient comes, therefore you're able to suspect that this patient has malaria and you're able to investigate and treat appropriately. I'll invite Dr. Agatha to take us through more about the clinical presentation of these patients.
Thank you very much, Dr. Afizi. So for malaria presentation, how the signs and the symptoms that the patients are likely to present with is going to differ. Is it the uncomplicated malaria versus the malaria with complications? So the uncomplicated malaria, the patient presents with fever, that's a high temperature. They may have body aches and body weakness. They may have reduced appetite. Headache is another common presentation. And for young children who may not be able to speak, they may show irritability as a sign of pain. They may also have vomiting and reduced appetite. They may have abdominal pain and even diarrhea. So for the other signs and symptoms that may present with could be pointing to complications. So complications are quite a number of them when it comes to malaria, but some presentations can include convulsions, what we call in the layman's language, what we call fainting episodes, or fits. That is likely to show cerebral malaria. They may present with passing very dark urine, which may look like black tea or Coca-Cola soda. They may even have reduced amount of urination. The child could go a whole day without passing urine, and that could show a complication on the kidney. The child could have difficulty in breathing. They may have very pale, they may look very pale when you look in their palms, on their tongue, and in their eyes. They may look very pale when they've developed anemia, and they may as well have bleeding tendencies. So the child could have bleeding from different sides as another complication of malaria. So you need to be vigilant, you need to look out for such signs. Do not ignore when the child presents with such presentations. Be very fast to bring them to a health facility.
I think Dr. Tentwa, maybe you could add on that, but maybe before Dr. Tentwa comes in, Doctor talked about malaria in children, but also in adults. We know that in adults, patients still with malaria, they can present with non-specific symptoms. Some may present just with abdominal pain, headache. They may not present exactly with the fever, but they may present with history of fever in the previous 24 hours. Therefore, it's upon you to really have the index of suspicion. Therefore, also in adults, still, if patient has anything causing his immunity, his habit of the body to fight disease to go down, like he has HIV, he has diabetes, he may present with malaria, but with non-specific symptoms. That's in terms of the uncomplicated. But with that, I will invite Dr. Tentwa to add on more on the clinical presentation of those who have severe disease. Doctor?
Thank you so much, Dr. Afizi. Just to add on what my colleagues have said, some of these babies actually, the mothers will report that the baby's eyes are becoming yellow. So it can also point to malaria, though there are other causes that can cause the eyes to become yellow, but also it is one of the severe forms of malaria. The other thing that is most also reported, the mother tells you, the child is so weak, cannot even eat, cannot even drink, very weak, and in most cases the babies, those children cannot even walk, so they are just actually carried by the mothers to hospital. Yeah, so most of it has been said. I just wanted to just add on some of the other symptoms.
Thank you, Doctor. Yes, still on the presentation as the complicated malaria, as we have said. Also, Doctor has talked about patients bleeding. So when you see a child with basic bleeding, don't underlook malaria. Don't try to any other whatever. Also could be malaria in its complication. But also patient can come with just difficulty in breathing. What we call pulmonary edema, water in the lungs. The child is not breathing. Don't think of only pneumonia, COVID. This could be TB, this could be malaria. So you should always think about malaria in most of these patients. In adult patients like elderly patients, they will come when they are weak, no fever, but they are generally weak. They are docile. You give them even the cup, they can do totally nothing. Think about what? Malaria and investigate them. Other patients also may just present with the just dizziness because of the low sugar. Just dizziness. Somebody is too weak, too dizzy. You need to suspect malaria more so as long as the risk factors are there. Somebody doesn't sleep under the mosquito net. Just, he comes too weak. Like they told us, like convulsion, don't think about meningitis, also investigate for malaria. Why? Because malaria is easy to treat and easy to investigate. I think, to summarize all this, we have said malaria can present either complicated or uncomplicated. If it's uncomplicated, it means the patient is not too sick, can take treatment from home, doesn't need to be admitted. But if it's complicated, it means the patient is too sick. As they have told us, could be bleeding, could not be breathing well. This should be taken. If it's taken as complicated, that means it has to be admitted and treated urgently. And I think with that, I do request the viewers that we should stop, one, underlooking malaria, saying, that can't be malaria. First check for malaria because it's easy to treat, and as we have seen that symptoms are not too specific. It's more so in adults and elderly children, as we saw in our previous episode, we said that adolescents, children up to around 12 years, we are seeing increasing number of malaria cases. So we should not underlook to investigate them for malaria before we start to treat them or to treat any other thing other than malaria. Then patients who have low immunity, adults and children, should think about malaria. I think with that, I do request that we can have a small break. After this short break, we shall come back with our next expert. We're going to look at how do we manage malaria, since we have seen it's a major cause of hospital admissions and hospital-related or community-related deaths.
This message is from the Ministry of Health with support from partners.
Attention all young people of Chigezi, Honorable Minister of State for Youth and Children Affairs and National Vice Chairman, PLU, Honorable Dr. Balambaruga Hariatenyi, cordially invites you to the Chigezi Youth Day Symposium and Rally. Join us this Friday, 21st February 2025 at Kakakunda Playground in Chigezi, Ruchiga District for an exciting event packed with Poverty Eradication Crusade, hear from key crusaders on strategies to overcome poverty, football, cheer on your favorite team in the NRM Youth vs PLE football match, entertainment galore. Enjoy delicious eats, refreshing drinks, and thrilling entertainment. Youth empowerment. Learn from youth livelihood coordinators and other youth program coordinators on how to benefit from government programs. Launch of basic skilling programs. Our special guest, Honorable Balambaruga Hare, will be joining us to make this event even more unforgettable. This event is proudly powered by Dr. Sylvia Alnaitwe, the driving force behind Ruchiga's development. Mark your calendars and gather your friends. We can't wait to see you there. 2026 Vote Mosei, President Yoweri Kaguta Museveni.
You are watching the DOCtalk Show.
This message is from the Ministry of Health with support from partners.
I do welcome you back from the commercial break, and we have already talked about the problem, the burden of malaria as an infectious disease, and also talk about how patients with malaria do present. In this episode, we're going to talk about how do we manage malaria promptly, so that we avoid the suffering and the deaths related to malaria. And with that, I'll invite Dr. Tentwa Emmanuel to take us through how best can we manage malaria, since we have seen that the biggest number of malaria cases, both inpatient and outpatient, occur in children. Dr. Welcome.
Thank you so much, Dr. Afizi. So as my colleague Dr. Agatha said earlier, malaria is classified into two. We have the uncomplicated and the complicated malaria, okay? So for the uncomplicated malaria, those children don't need admission. So what we normally do, we give them, we use the what we call national guidelines for management of malaria in Uganda. And we have actually a book, it's called Uganda Clinical Guidelines, which has even been revised. We have the current one, 2024, I think. So for uncomplicated malaria, the first line is artemether-lumefantrine combination therapy. And commonly, we use Coartem, okay? So in children, you cannot write any anti-malaria without taking weight. So basically, this Coartem, we use the weight. You have to follow the weight, and it has we use weight bands. So from 5 to 14.9, we normally give 1 tablet twice a day for 3 days. 15 to 25 kilograms, we give 2 tablets twice a day for 3 days. 25 to 35 kilograms, we give 3 tablets twice a day. And above 35 kilograms, we give 4 tablets twice a day. Okay? However, there are children, you give the first line treatment, which is Coartem, the artemether-lumefantrine combination, and it doesn't help. We also, according to the guidelines, we have the second line, which is dihydroartemether piperacin combination. Most people call it DRTF, other people call it duocotexin. Okay? It also has a different weight band. We use weight to prescribe a particular drug so that we avoid underdosing or overdosing. Because if you underdose, remember, you can cause resistance. Okay? And if you overdose, more side effects the child, which are harmful. Others can affect the child's intestines. They can get diarrhea, they can vomit. Others, it can even affect their heart conduction.
So at that point, we're telling our viewers that they should stop sharing drugs. In a family, you find the child has Coartem, takes 2 doses, then they give the other child. So we should take the treatment to completion, and also in our facilities, let them not just look at patients and say that this one, for you take 4, for you take 3. People need to take the weights, the actual weights of these patients. Yeah.
Thank you so much, Dr. Afizi. So the other thing that is very important, even if it is uncomplicated malaria, they may have a fever. So we also have to give them some paracetamol. Commonly, we call it Panadol. So we also use the weight. Normally, we use 10 to 15 kilograms per kilogram body weight, and we give it 8 hourly for 3 days. We also do supportive care. You know, these students, even though they have uncomplicated malaria, but they may have poor appetite. So supportive care, we tell the mothers, our caretakers, to give more feeds. If the baby is breastfeeding, frequent feeding. If the baby is off breast milk, they can give juice. And remember, for Coartem, it needs soluble feeds, okay, or food. So Coartem, actually, it is surprising. You have to take it with milk or fatty food for better absorption. So that one is very important. The other thing is because we are not admitting these babies with uncomplicated malaria, we normally educate our patients and the mothers on when to return to hospital. Because remember, it can start as uncomplicated malaria, but my friend, it can end up become complicated. So normally, because it is home-based care, we still have to educate the mother on when to return. For example, if the child is vomiting everything, return immediately. If the child develops a convulsion, or what we normally call fits, return immediately. If the baby is becoming so weak, return immediately. If the mother sees like a tea-colored urine, Coca-Cola soda urine, come back to hospital. If the amount of urine is reducing, the mother is telling you, for the last 24 hours, the child has not passed any urine, please return back. So if the baby's level of consciousness is going down, the baby who was awake, even though the mother tries to wake up the baby, cannot respond please, we tell them to rush back to hospital.
I think Dr. Agatha, you can take us through complicated malaria.
Okay. Thank you very much, Dr. Tentwa, for that elaborate discussion on uncomplicated malaria. So for the complicated malaria, maybe I'll first start to talk about the complications that can happen with malaria. So malaria is such a serious disease that it can affect almost every body system on our bodies, starting all the way from the brain to the kidneys. So it can cause what we call cerebral malaria, whereby there are certain effects it causes on the brain that the child could either have convulsions or go into a coma. Malaria can also affect your kidneys, what we call kidney injury. That's why we are emphasizing if a child is not passing urine, has taken some good number of hours without passing urine, or is getting body swelling, which normally starts around the eyes, it could be a fact that the malaria has affected the child's kidneys. Malaria can as well affect your breathing and cause them to have difficulty in breathing, what we call respiratory distress. It can also affect your blood system, that you may have problems with clotting. So the child can present with bleeding tendencies, that where they prick, the child keeps bleeding. Or they can even just start have bleeding from different orifices on the body. The parasite likes to eat up glucose from our blood system. So the child's glucose could be so low, even the adult, like Dr. Afizi mentioned, some of the signs being dizziness because of low blood sugar, and what we call hypoglycemia, because the parasite will feed on your glucose, so you may become too weak and have very low glucose. And if the brain is not getting enough glucose, you could either get the fits, or you become confused or very weak. Malaria can also cause what we call anemia. Because the way the parasite does, it affects your blood cells that carry what we call hemoglobin, the red blood cells. So as it infects them, they keep rupturing. So the child can present with anemia. And how do we know this? They look very pale when you check in their palms or the soles of their feet. The eyes look very white, and they also become very weak. Sometimes the breathing can be, they get fast breathing because of having very low blood in their system. So how do we manage this complicated malaria? Complicated malaria is managed as inpatient. So this child is going to be admitted if they have any form of complication. As I've mentioned above, in addition to a child who is not eating, because in children, we look at the ability to feed as one of the signs. If a child is refusing to eat and is vomiting everything, we also admit that child, irrespective of whether they have the other complications that I've talked about or not. So when we admit the child, according to the national guidelines that Dr. Tentwa talked about, for inpatient management, for malaria, we use intravenous artesunate, the injectable artesunate, which is given according to the body weight of the patient as well, whereby for children weighing 20 kilograms and below, we multiply it by 3. So it is 3 milligrams per kilo for the children weighing up to 20 kilograms. And for children who are above 20 kilograms, we multiply it by 2.4. So the dose becomes 2.4 milligrams per kilogram weight. And it's given in 3 doses, which are specifically, they have specific timing. At 0 hour, that is the time when you diagnose the malaria, you give them at that hour, it becomes your 0 hour. And then the same dose is given 12 hours later from your starting time, and then 24 hours later from your starting time. So the treatment is very specific according to the dose and timing, because these doses, the additional doses of artesunate, they augment in the clearance of the malaria from your body. The effect is additive on the previous doses. So it is very important to give the dose in the right time, as I've mentioned, 0 hour, 12 hours from the first dose, then 24 hours from the first dose. So, and after that, we do a repeat check of your malaria, the blood slide, to check the number of parasites for clearance, hoping that if it has worked, we shall talk later about the resistance. But after the 3 doses, if the malaria parasites have decreased and the child also looks clinically better, we go to the oral continuation dose, which is the oral, the tablet form, which is, in this case, we go to the DOCtalk and or the DOCtalk. Thank you very much.
Okay. Thank you very much, Dr. Agatha, for that, and Dr. Tentwa in the management of malaria. We have seen that really uncomplicated. We give oral treatment, but we counsel the patient, both adult and children, that if symptoms persist or symptoms worsen or new symptoms come in, come back to the hospital for re-evaluation and readmission. The malaria could have moved from simple, which are complicated, to complicated. Yeah? And also we saw that for simple malaria, we start with the coartem, which is our lumefantrine. Then where that falls, we go to askena, which is the diadrone and methane with the DOCtalk, right? As our second line of treatment for the simple malaria. However, also, Dr. Tentwa alluded to this, that if that falls, if the patient becomes severe, for severe malaria or complicated malaria, we're going to treat it with the intravenous treatment with a minimum of 3 doses, but however, we can move up to 5 doses, depending on the patient's ability to take in oral. And not forget that after the 3 or 5 doses, you need to follow it with a 3-day course of oral antimalarial. That's where people fail it, that they take the IV and they end there. After that IV of severe, you are supposed to continue with the 3 doses, the 3-day course treatment of of oral treatment to ensure that we clear the malaria parasites. And we said that on top of that, also we treat other comorbidities which come with malaria. We talked about the fever, we talked about the convulsions, we talked about the anemia, we talked about fluid overload, the renal failure. All those have to be managed. With that, I need to thank you viewers for your attention and time, and we request that we're going to go for a small commercial break, and when we come back, we shall talk about malaria resistance and also prevention.
This message is from the Ministry of Health with support from partners.
International Women's Day is celebrated annually on 8th March. It is a time to reflect on progress made, to call for change, and to celebrate acts of courage and determination play by women. On Saturday, 8th March, Uganda will join the rest of the world to commemorate International Women's Day. The national celebrations will be held in Changwanzi district under the theme Accelerate Action for Gender Equality. The President of the Republic of Uganda, Yoweri Kaguta Museveni, will be the chief guest. Join us for the live broadcast to witness outstanding women receive medals in recognition of their achievements and contributions to the country. Happy Women's Day.
You are watching the DOCtalk Show.
This message is from the Ministry of Health with support from partners.
Yes, good evening viewers. I do welcome you back to the DOCtalk Show, sponsored by Ministry of Health in collaboration with Jinja Regional Referral Hospital. Previously, we have talked about the malaria burden, the clinical presentation, and the management of both complicated and simple malaria. And we broke off when we were talking about the complications, and we had not finished. We had talked about a few complications and a few supportive treatment. I would like us to start from there and invite Dr. Agatha to continue with that. Doctor, welcome.
Thank you. Thank you very much, Doctor. So as we manage the complicated malaria, we must as well manage the complications. In this case, the supportive management. For a child who has severe anemia, who has very low blood counts, we transfuse them with blood. And severe malaria anemia is one of the leading causes of death in malaria. So we need to always know the blood level of this child, but sometimes we may need to use the clinical picture. Child is very pale, is having fast breathing. We may use that to go ahead and give them blood. And then for a child who is having difficulty in breathing, we support them with oxygen, or children who are having the fits, the convulsions, we also keep them on oxygen. We also manage the fits. We give them drugs for convulsions. And then we need to also give them feeding plans for children who are very sick. Sometimes we may need to put a tube through their nose into their stomach to be able to give them feeds. However, sometimes mothers may not really be very comfortable with this, but it's a life-saving intervention that if a child is not able to take in food, and malaria, as we've seen, that it actually feeds on your glucose, you could actually become worse. So please be receptive of this procedure when the doctors and the clinicians feel like it's necessary. Please let them go ahead and put a tube in your child's nose to save their lives as a way of giving them something to eat. And then children, as I mentioned, they could present with vomiting and diarrhea. So in this case, they may get dehydration. So we also give them fluids. Sometimes the fluids contain glucose, sometimes it's just to rehydrate the child, and also in a way of preventing further kidney damage. So fluids are another form of supportive management for these children. And unfortunately, though some children could actually go ahead and get a kidney injury from the severe malaria, and we also manage it according to the level of the kidney injury. Sometimes all they require is the fluids to be able to let them pass urine. Sometimes if the child's kidneys are really shut, they may move up to the level of needing dialysis, and even sometimes a kidney transplant later in life, if not well managed. Thank you.
Okay, thank you, Dr. Agatha, for that. Yeah, dialysis is really an artificial way. Machine should work to clean the blood, because it's supposed to clean the blood for the viewers. And thank you for that. Yeah, after looking at the complications, all of us, we see that, yeah, patient may be given the right drug, right dose, right duration. But we are seeing that despite of that, we see increasing number of malaria cases with the slow clearing of the malaria parasites. When we give you the drug is supposed to kill all the malaria parasites from your blood, so that after, when they check, they find there's no malaria in your blood. But we're seeing increasing number in some areas within the country. We have Tororo area there, then we have the northern Uganda, and this is a call to say that probably there is resistance coming in. And with this, therefore we are wondering, could it be that people are sharing the drugs? Could it be that the malaria parasite has changed in that when you give the drug, it doesn't work? Yeah, we have had reports, I think from Rwanda, where this was noted, and also we have had reports similar resistant genes in Rwanda have been found in different places in Uganda here, in northern and the eastern part. Therefore, there is an element of malaria resistance, and this calls for more research to find either new malaria compounds, because we are seeing that out of 10 children treated with some of these antimalarials, you may find about 3 or 2 may continue staying with malaria parasites even after completing what? The treatment. And that means that probably either the drug is not what? Is not working. And that calls for more research, and we need to thank the researchmen who are trying to research to find maybe other new compounds which have slightly or completely different mode of action, so that we can fight this killer disease, what? Malaria. So with that, we know that as government, the number of interventions have been made. One of them is that all children, all adults, all patients with severe malaria who are discharged, they are supposed to continue on malaria chemoprophylaxis for 3 consecutive months. They come back, we check for malaria, but we give them antimalarial, DOCtalk dihydro, and methylene piperacin. We encourage and request health facilities to make sure abide by this protocol or by this guidance, so that all those patients with severe malaria, they stay on malaria chemoprophylaxis. We have seen also there are patients, special group patients, like sickle cell patients. Also, they have been found to have slow malaria clearance by some research and papers done. And here we have found out that these patients also at discharge, they should be given dihydro and methane instead of what? Coartem. Because those who were given coartem, they were found to stay with the parasites for a longer period. And even they were found sometimes to have some of these resistant genes or strains. So such special groups, we end up giving them what? Coartem. And this still calls upon for more research, so that maybe in the next 2 or 3 years to come, we have those malaria compounds, probably which have different what? Mode of action. All of us to recall, we used to have chloroquine, right? Which we used for quite a while. It became resistant, then we went to coartem, and also this one, if you get to it, we shall get another compound. Yeah, because the parasite also keeps on what? Changing. So, what does this mean? We call upon health workers to abide by the treatment guidelines, which are clear. Let treatment be based on dose, on weight, not on appearance or on gut gestures. Let it be weight-based, and let people complete the treatment. Encourage them to complete the treatment. If it's treatment to be taken twice daily, let it be taken twice daily for 3 days, consecutive days, and at the actual time to avoid this what? Resistance. Then also, patients who are treated with IV antihistamine, let us use weight treatment, not just estimating without taking weight. Therefore, we call upon health workers to weigh the patients before giving the treatment and adjust the treatment according to their weight. This is the only way we shall avoid resistance. And also we call upon families and communities to avoid sharing anti-malarial drugs amongst other households. Let the treatment given to one child, let that child complete the treatment, not to be shared among us other patients.
Something small in addition, because we're talking about the strict timing of this medication, we have unique, of course, private facilities that are sometimes outpatient clinics and are not able to admit. And you realize that someone is on a testinate, is an injection, is being let to go home, and then they come back for that second dose maybe, and the timing is not right. So in addition to emphasizing the health workers to give the right doses, let us be able to refer. If you're not able to give the second dose at the right time, maybe your unit will be closed, please refer to where the child could get proper admission and inpatient treatment. You could give the first dose and write clearly what you've done, and at the time you've given, then you refer them to completion of treatment. And patients should not as well be stubborn, especially in the urban areas, refusing admission. If the clinician or the doctor thinks that the child needs to be inpatient, please do not say that, oh, me, I'll be able to drive in at 2 a.m. to get the second dose. It should not be like that.
To ask the health workers, now that we've heard our colleagues saying that we have increasing malaria resistance in the country, when we admit these children and they have a positive blood smear, please, as health workers, we should do follow-up, we should do repeat blood smears. Okay? It is advisable right now, you cannot discharge a child who has suffered from malaria without repeating malaria smear to look for parasite clearance. Because, as you know, you might admit the child, put on a test net 3 doses, you discharge on oral, but the malaria is still there without being cleared by IV assessment. So my humble request to health workers, please, before you discharge a patient, at least you can do malaria test 3 times. On admission, once you confirm it, after 24 hours to 48 hours, you can look for clearance. How is the parasitemia like? How are the levels going down as far as parasites are concerned? And on discharge, please, health workers, let us repeat a blood smear before we discharge patients. Because if you do MRDT, it will continue being positive for 14 days. So don't rely on MRDT for discharge, but let's do a blood smear so that before discharge, we are sure we have cleared the malaria parasite. Thank you.
Okay. Thank you, Dr. Tentwa. Even just to add on that, if they still have malaria parasites, admit them, and even the guidelines allows you can add even a 4th and a 5th IV antihistamine dose. Therefore, it's not cast in stone that it should be only 3 doses. Now we are going to talk about how do we prevent it. Yeah, this disease is one of the diseases which can be prevented. Meaning that when you prevent it, you reduce this suffering, these deaths. How best can we prevent this malaria infection? I'll invite Dr. Tentwa to take us through that. Doctor?
You know, there's a saying that prevention is better than cure, okay? So we don't want patients to come to hospital with malaria. We want to prevent it as much as possible. That's why the Ministry of Health, Uganda, has injected a lot of money on preventive measures. And if I may take you through some of the preventive measures, if you move to the lowermost, that is the parish or village, government of Uganda actually has supplied free insecticide-treated nets across the country. So we are so grateful actually to the Ministry of Health for having supplied insecticide-treated nets across the country. And the only challenge we are having, we need to educate our mothers about why insecticide-treated nets must be used. Because as we may know, mosquitoes normally bite us from like around 10 p.m. when we are asleep, right? And when you are sleeping, you are snoring, you don't know what is happening. And the mosquito is taking a blood meal. And as it takes a blood meal, it is busy putting in the parasite in your blood. And remember, it bites you, then it goes and bites another person, it bites another person, and in the whole family, all of you are infected with malaria. Yet, when you use an insecticide-treated mosquito net, remember they are treated. So once a mosquito falls on that net, automatically it will die. And it cannot even reach our children and even the adults. So in that case, we shall even be preventing transmission of malaria within even our household. Okay? And remember, every time you get malaria, you go to hospital, the government is injecting money, water bills, electricity, the medicines, government is injecting money in medicines, the beds, so the health economics. You understand? So we should think bigger. So when you prevent, the government can save a lot of money, which can do other activities for the country. The other thing that is very important is that we should close our windows and doors early. By around 5, you are meant to have closed your windows and the doors. Or if you have to leave them open, you should put a mesh. Most of these windows now, people can modify them, and the doors, you can put mesh so that the mosquitoes cannot access inside of their houses. So the other thing that the government actually has tried to do is the indoor residual spraying, like in northern Uganda, in Apache, in Tororo, in Elira. And actually, when they do monitoring evaluation, those areas which have benefited from indoor residual spraying, the occurrence of malaria has drastically gone down. Okay? The other thing is, within our community where we stay, the bush, we should make sure we slash the grass, okay? The broken bottles, they should not contain water, because stagnant water, that's a breeding place for what? The mosquitoes, okay? The other thing is the stagnant water, it can be all over the place. The broken bottles, the tins, name it. So we should make sure we clear our environment.
I think in addition to that, like the issue of the stagnant water, in the Busoga region, we already told you that one of the economic activities is agriculture. And one of the crucial issues is the sugarcane planting and the rice growing. So we should encourage the community probably not to grow sugarcane up to the house. Because this sugarcane, they harbor some of this water and also to other breeding areas, right? So I think that maybe would help us to prevent some of these mosquito bites. And also maybe putting on long-sleeved clothes at night, and maybe mosquito repellents for people who can't avoid that. I think with that also I'll invite Dr. Agatha to tell us more about some more preventive measures. Yeah, Doctor, welcome.
Thank you. I'll talk about the newest invention in the prevention of malaria, which is the malaria vaccine. Thanks to science and researchers who have been able to come up after a series of lab testing and a lot of research and a lot of work to come up with the malaria vaccine, which is called Mosquirix. I think that's the type which is available, or the government is yet to adopt. So malaria vaccine has been invented, and it's very soon going to be launched by Ministry of Health to be available in the national vaccination program. So malaria
UBC, inspiring Uganda.